So I'm a clinician, and mostly I give small workshops, so I'm not used to speak English when so be patient with me, okay? I brought my Ayala, my daughter. She's a doctor in psychology or child psychology, and she's a specialist in child trauma too.
Computers.
What?
Computers.
And in computers, yeah. And she will help me with this presentation. And I am very happy to be here. We are very happy to be here because just what we heard till now is make a new thinking about combining things, and it's very interesting. So what I want to talk about is about the diagnosis of psychotherapy, and that diagnosis and psychotherapy combined evidence-based science as well as clinical intuition. And it's important to take both things into consideration when we are going to diagnose and treating dissociation. It is difficult to diagnose dissociative disorder because several reasons. The first one is that the definition of dissociation differs among various researchers and various psychological models. Therefore, it is difficult to know what to measure. Ross is trying to deal with this issue very seriously. He's writing few paragraphs in his book about dissociation, what is dissociation. But in my opinion, he strays away from psychology into philosophy and linguistics, right, Ross? And it is not really solve the problem of what is really dissociation. Many professionals are skeptic that to the existence of the dissociative disorder in general and during childhood particular, due to the fact that the central symptoms may be misleading and appear like another problem, like attention deficit disorder, learning disability, conduct disorder, oppositional defiant disorder, post-traumatic stress disorder, bipolar disorder, even psychosis or epilepsy. For example, just 1 year ago, Jelisic has recently wrote a paper, and he goes so far as denying the existence of dissociative amnesia following trauma. He is acknowledging only post-traumatic hyperamnesia. Professionals are reluctant to submit a dissociative disorder diagnosis for fear of criticism and rejection, resulting from negative context with the concept of dissociation. They carry in the general and professional culture. For example, 20 years ago or 30 years ago, we were in Jerusalem. Professor Vanderhart was giving a lecture, a workshop about dissociation, and somebody burst in the room. You remember? Somebody burst in the room and said, "It's all lies. Dissociation is a lie. You are teaching lies." And we just threw him out of the room. So, dissociative symptomatics profiles vary from one person to another person, and from one trigger to another trigger. This makes evaluation of diagnosis of dissociation symptom much harder. In this way, the same patient may exhibit a very different symptoms in different times or different contexts, and receiving varying diagnoses. When somebody comes to me and he has borderline diagnosis, somatic problems, and other psychotic diagnoses and things, I always think that it might be dissociative diagnosis, because other professional, every professional saw another angle of the diagnosis. Thoughts, feeling, association, and memories which have been developed while a dissociative state, they are not automatically accessible in non-dissociative states. And therefore, the person is not necessarily aware of them and has difficulties reporting gaps of differences in feeling and memories and emotion. So you have no access to these parts of him to understand the whole diagnostic parameters. Consequently, the result is often wrong diagnosis and wrong treatment, which is ineffective or even harmful. In the book we are writing now about dissociation, me and Professor Witztum, we give an example of cases of post-traumatic dissociative psychosis that was misdiagnosed as a schizophrenia and treated with antipsychotic medication, and the treatment was worsening his dissociation, and the treatment make it worse, make the problem worse. And for this reason, literature recommends comprehensive evaluation, which is assisted by a variety of tools. We know about the structure of semi-structured interviews, projective tools like Rorschach, trauma questionnaires, which is included reporting on dissociative symptoms, self-report questionnaires regarding dissociative symptoms. You just heard about, and other tools. And we have the clinical observation. Today, I want to talk about the clinical observation. So another time I want to say that in the book we have a big chapter about other kinds of all these tools, but today I want to concentrate on clinical observation. The purpose of the lecture is to help the clinician identify the dissociative patient from the start, even before structured evaluation. Indication for the existence of the dissociative, but in my clinics, I have some kind of indication that may give me a thinking about the patient being dissociated, okay? So I give you this kind of hints I collected in my clinics. When in the phone, the patient call and ask for an appointment, you can see that it is possible to identify some kind of dissociation. Mostly they have I'm talking about the adults, not the children, okay? They have a lack of concentration and they have some kind of detachment. It's difficult to set an appointment during conversation as the patient repeatedly asks to change the date or the time or the appointment. And said you can talk about Sunday 5 o'clock. 5 minutes after this, they call and said, "Oh, I'm sorry, I was not realizing that Sunday I have something else, and give me another time." You give him another time, and then 5 minutes after this, they call and say, "I want to change again." When I ask them in the phone what the problem is, they have very difficult for them to explain what is the problem, and they change the explanation during the talk, the 5 minutes talk. What is the problem? They change time to time the explanation why they need the help. And one of the most interesting things is that they talk about themselves as a second person or third person. I said, what the problem is that you have headache. Sometimes you have headache. Sometimes you have, and said, I have headache. I don't have headache. No, I have headache. Okay? So you know that there is something that make you think about dissociation. On the way to clinics, it happens time after time. That's in the way to clinics, although they use Waze or GPS, these patients get lost many times, and usually needs to be given instruction again and again over the phone several times till arriving safely in the clinic. Sometimes I take my mobile phone and go to the street and giving them instruction that again and again until they saw me and I called them to come to me. This may occur even if they were in my clinic few times before. Means the third time or fourth time, and maybe even fifth time they get lost. During the first meeting, in the initial encounter, during the first meeting, it's like over the phone. They are confused. They don't look in my eyes. They look down. They have difficulties to explain the reason for seeking help and might refer themselves again in second or third person. Yesterday, I had a patient to come, and I know he's dissociative, and he said that he has a bad week. So I asked him, what happened? He said, you can see all these items in the news. All these rapes in all over the board. Israel is raping other people. I said, what you mean I can see the news? Oh, no, not you. I. But why you are pushing me to say I? It's better to me that says you. And then it's difficult for them to take the responsibility for the thing or the feel. During the conversation, there come moments of detachment to which the person is unaware. And if I say, where have you been? At what are you looking there in the corner of the room? They become very anxious. They don't know what I'm asking for. They become confused. Sometimes they don't understand what I require from them. When we are speaking, they are going from one topic to the other, from one state of mind to the other state of mind, for sometimes from being distressed to being relaxed, changing their feelings. Sometimes the thinking has disruption. There's no continuity in thinking, in memory. They are not in concentration, usually with damage, without damage in judgment and without damage, without psychotic content. When I test them for hypnosability, majority of them are high hypnosability, high hypnosable. and very easily go into hypnosis. Time and again, they said that there are gaps in historical memory. Like, I don't remember between age 5 or to 10, or age 10 to 15. I don't remember anything about this gap. They have sometimes amnesia of various types concerning certain events, sometimes emotion, sometimes behavior. There are striking gaps between forgetting and between the detailed memory. Sometimes look like flashback and like OCD. They may be states in which certain information which is accessible to memory at a certain time is inaccessible to the memory in another time. The person reports gaps in different functioning level which indicates different ego states. For instance, the person could be most successful in the business, but finds it hard to mention a long-term emotional relationship. I had somebody came to me that was very, very successful in high school, and when he went to try to go to the university and had this psychometric, and he got only 545 or something like that. That is very low. And he came to me and I asked him what happened. He said, I didn't remember anything. So I made him under hypnosis, and he could learn to be connected with his knowledge when he's taking the test. So he went back and get 750. So they was very, very suspicious with him. So he did what you did it, that you came from 525 to 750. So they gave him a one-on-one questionnaire that is very, very stressful. And he went higher to 780. So it is very, very, very important to find some ego state that make you, that harm you, that make you not being successful. Sometimes people come and they report self-harming, and when I ask why, they are unable to identify why they did it to themselves. I have a nice girl that is she's very looking nice, and she's very engaged with this looking. She wants to have a good looking, but she is cutting herself here. And after that, she has scars, and she's very distressed with these scars. And when I ask him why she's doing it, she can't explain why she's doing it. Sometimes they report hearing voices in their head. And this is without evidence of schizophrenia or psychosis. I had someone came to me with a headache, very strong headache, and 30 years old woman with a very strong headache. And nobody finds why she has had this headache. So after I met her in hypnosis, we find 35 voices in her head arguing. And these argues make her not being able to do anything. She was sitting at the home suffering and taking more and more and more drugs for headache. So after I put her in the hypnosis and find all these voices, we did a grouping of ego states. We did some which ego states can do together, and we came out with 3 ego states that could work together at the end. Three representatives for the 35, 3 representative of the 35 voices. And when she had only the 3, she had no headache, and she could go back to work, and she got married and has a reasonable life. They may also report either over responsibility of or deficiency on affective and sensory level, maybe high or very high or very low. Sometimes they complain and unexplained pain, like this woman with the headache, a specific somatic condition, like the hand, or alternating somatic symptoms. Sometimes it's in the leg, sometimes it's in the head, sometimes it's the back, and it changes. When they leave the room, the clinics, they sometimes stand in the middle of the room, and they don't know how to do, what to go. I have 2 doors in my clinics, one to the home, one outside. And sometimes they stand and they don't know which door to choose, and sometimes they choose the wrong door. And it can happen after weeks or months that they are in clinics, and they know where they come from and where to go, and they still get confused. As the therapy proceeds, there will appear inconsistency in expression of cognitive, verbal, creative, and other abilities. Sometimes background of patient's trauma, PTSD, or complex PTSD will emerge.
That made you think.
That's what's, okay, because I jumped.
I think so.
Okay, but it also proves the importance of using hypnosis in treating a dissociation patient. Thank you.